welcome everybody who is here on the National Advisory Council and in the room, and those viewing on the webcast. And just kind of as a reminder to people, because we do have people on the webcast, be attentive to using your microphones when you talk. So I have a few housekeeping notes to get started. For the council members, if you need transportation to airports, train stations, etc., after the meeting, please sign up at the registration desk so they can organize that for you. For those in the room who might be interested in making a public comment, there are two opportunities for that today at 11:45 and at 2:15. We just ask that you sign up at the registration desk so we can plan for that. The cafeteria is located across the hall on this floor, and you can get all manner of food and beverages there until 3 o'clock. So let me just start by asking people on the council to introduce themselves, and start with Christina.
Good morning. I'm Dr. Christina Calamero. I'm a senior nurse scientist and the director of research and evidence-based practice at Children's Healthcare of Atlanta.
Good morning. I'm Monica Peak. I'm an internist and health services researcher at the University of Chicago, and I mainly do health disparities work in low-income African Americans with diabetes, and do a lot of work around shared decision-making.
I am Don Goldman. I'm Chief Scientific Officer Emeritus as of now at the Institute for Healthcare Improvement, and also I'm over at Harvard and Harvard T.H. Chan School of Public Health in Boston Children's Hospital. And as we were discussing this morning in our disparities report meeting, I'm teaching an undergraduate course at Harvard College, and I'm trying to bring how we translate health services research and data into something that our up-and-coming students can understand. So you may hear that perspective today.
Good morning. I'm Lucy Savitz. I'm the Vice President for Health Research and the Director for the Center for Health Research, Kaiser Northwest, and the Director for the Center for Health Research in Kaiser, Hawaii.
Morning, Kevin Grumbach. I'm Professor and Chair of the Department of Family and Community Medicine at University of California, San Francisco, and Vice President for Population Health for the UCSF Health System.
David Atkins. I'm the Director of Health Services Research at the VA.
Hi, my name is Paul Rosen. I'm a pediatrician. I'm one of the medical officers at CMS and working on the Transforming Clinical Practice initiative.
Hi, I'm Sharon Arnold. I'm the Deputy Director of AHRQ.
You can say your name, but I'm going to give you a longer.
I'm Gopal Khanna, Director of AHRQ.
And I'm Beth McGlynn. I'm the Vice President for Kaiser Permanente Research and the Executive Director of the Center for Effectiveness and Safety Research at Kaiser Permanente. So let's see. And then I know that we had a couple people who might be calling into the meeting. Have you got evidence that? So Jose, would you like to introduce yourself?
Sure. This is Jose Escarce. I'm a professor of medicine at UCLA, and I have a question. Is it okay if I ask it now?
Sure.
Yeah. So I have an email here from Jamie, but so I'm on the phone, and I have turned off the webcast because there is about a 20 or 30-second lag between what's actually going on in the room and what I'm seeing on the webcast. I don't know. So I don't know if I should be on the phone or on the webcast, because obviously with that 30-second lag, if I'm only on the webcast and I try to speak, it'll be like 30 seconds after the thing has happened. So I just wanted to know how to manage that, and that may be an issue for other people, or it may just be me.
Hi, this is Jamie Zimmerman. I'm the designated management official for the NAC. Jose, I would say you need to be on the call-in number that we gave you, this one, because that allows you to participate in this meeting. So if it's distracting, yep. And so I would just close the webcast or mute it, or in that way. And you have the slides ahead of you, so you should be able to follow with us.
Okay, very good. Thank you.
And then is Robert Tippins?
He's supposed to call in, but I don't think
he isn't on yet. Okay. All right. And, okay, so the first order of business is to take a look at the minutes from the November meeting, and if those are in your folders, and if anyone has any changes or edits, let me know. Otherwise, I would entertain a motion to accept the minutes.
So moved.
Second? All right. All in favor?
Aye.
Any opposed? I shall sign them in a second. Okay, great. It is my pleasure to introduce Gopal Khanna, sorry, I'm like shifting papers around here, who is the director of AHRQ as of May 2017, so still getting used to the town, although this is a return visit for you, I believe. You have his bio in your folders, but I think it's exciting. He's got experience at the state level, the federal level, and in the private sector. And I think you'll see from his bio, he has considerable experience in IT, something very important in healthcare. This is not his first tour in Washington. You might note that he served in the second Bush administration in senior policy positions. And so we're delighted to have you here and have a chance to get to know you a bit better. So I'm going to, without further ado, let people read the detailed descriptions of his experiences and turn it to you to give us the director's update. And I'll pass you the mic.
Thank you, Beth. Thank you so much. Yes, I am indeed really pleased to join you today for my first National Advisory Council meeting. It's a pleasure to be here. And now that I've been here for a little over 2.5 months, I thought I would take a few moments to share with you my vision for where we are going and headed. After that, Sharon will give us an update of the work in progress and where we are and what we are doing. But before I start, let me thank you all for your service to the National Advisory Council. It's gratefully appreciated, the time that you spend, and I hold you in great admiration for your work and your help that you've extended us over the years. On behalf of AHRQ, HHS, and American people, I would like to say, please accept our thanks. To give you some context of where we are going, let me share a couple of things. Way back when I came here on board in May, just before my arrival, Secretary Price had announced his Reimagine HHS initiative, where he challenged all of us, 79,000 employees, including myself, to think boldly, to think outside the box and imagine and envision how we can serve the healthcare system and the American public efficiently, and more effectively. I seized upon that opportunity immediately and I said to myself, let's reimagine AHRQ and see how we can do what we are doing even more efficiently and effectively going forward. And we got our staff engaged. It's been a very exciting process. Our management team, our leadership team, and the 4 areas we thought are of significance important given the Secretary's framework for Reimagine AHRQ, as well as our core competencies. One that came out loud and clear was how we use data for better understanding our healthcare system and for making the information available to the physicians. The second was creating the next generation of scientists. The third area came up was the whole process and need for accelerating the system's improvement. And finally, working on how to take a more holistic 360-person view of the individual and the patient we serve. As you may know, and I'm sure you've heard about the Secretary talking about his 3 priorities: opioid crisis, mental health, and he also talks about childhood obesity. I call them the burning platform. He also points out 3 other areas that he needs us to pay attention to. One is physician burden. The second being focusing on interoperability. And finally, more effective use of evidence in practice. I call these the pain points in the system. And finally, there is the grand challenge before us, and those are the unmet needs that have been unleashed by the availability of data, which is flowing at us with enormous velocity, variety, and volume. And that has created unmet needs that we need to think about as to how we can leverage data for better outcomes at the point of care so that physicians can have synthesized information when they make decisions and have a more complete picture of the person they care for. This brings us back to my vision for the agency. So let me talk about our core competencies. Our core competencies are world-class research on quality and safety, something that you know about very well over the years. Development of practical tools and training to support real-world implementation of evidence into practice, taking evidence into practice, and the use of data and analytics to identify problems and track trends. I would like to see us leverage these core competencies to achieve the Secretary's vision and the priorities. And if we do this thing successfully, we will reduce the burden on physicians, speed up the pace of scientific discovery to the bedside, and improve the use of not only the evidence, but also serve as a bridge between research and implementation. These goals can indeed be achieved by us focusing on our core competencies. Recently, data from AHRQ, which was published and it covered extensively on opioid crisis, gained national attention. AHRQ is the go-to resource for healthcare data because our data is universally accepted as of high quality and accurate and actionable. The reason I'm saying is that these core competencies are extremely important for us to leverage going forward. Similarly, AHRQ is exploring ways to increase access to medication-assisted treatment for opioid use disorder in rural primary practices. The practical findings identified through these grants will provide helpful information and resources to expand access to badly needed treatment. These are but a couple of examples to demonstrate that AHRQ is uniquely qualified within HHS to fulfill the promise of the American healthcare system. AHRQ can speed up the process of new cures developed by NIH to the bedside and help physicians understand how to successfully meet the payment priorities outlined by CMS. Let's think of, for a moment, our distinguishing features. And there are a couple of them I'll point out. One is that AHRQ enjoys strong working relationships with physicians and other clinicians, including but not limited to primary care environment. Our broad-based approach, really indeed a broad-based approach to working with clinician and the clinical marketplace sets us apart from many entities because we have a much larger reach collectively working with our partners. Similarly, we enjoy an array of partnerships with those who produce and translate research. These include our evidence-based practice centers, the researchers whom we fund with investigator-initiated research grants, and many other such arrangements. AHRQ's focus on how of healthcare identifies practical solutions to our most pressing problems, like making sure physicians understand how to treat opioid addiction, And our focus on primary care means that the solutions we identify will reach the largest number of Americans, because primary care is where most of us begin our primary care journey. We achieve these goals by developing ways to incorporate new innovations into the workflow of doctors and nurses. AHRQ has deep expertise in generating the knowledge and tools to make it easier for them to incorporate evidence into their practice and use data to improve quality and safety. There is a compelling need to explore and invent new avenues for data and information to be used to learn and understand how to continually improve and provide better care. That's a huge opportunity. The National Academy of Science and Medicine has called this facilitating a learning health system. My predecessor, Andy Bindman, talked about it extensively as this being a unifying concept for AHRQ's work, and I embrace that. I know this has been a topic of conversation at past NAC meetings. Today, David Myers will provide an update on our activities in this area, and I look forward to your thoughts and suggestions. AHRQ is also well known for our analysis of large data sets to understand healthcare trends. With access to additional data sources, we can provide richer answers to today's questions that remain unanswered, and be prepared to answer questions that we have not even thought of yet. We can acquire, link to, and use the full array of federal data sets and learn to incorporate real-world clinical data. As I said, there's enormous amount of data flowing, and we've got to learn to harness, integrate, and use that data effectively. We're starting to get there with our annual report to the Congress, the Quality and Disparities Report, which demonstrates how quality and safety are improving and where opportunities for improvement remain. I believe QDR is a first step towards achieving the 360-degree view of our systemic and community-level challenges, and I want us to go further. That holistic view is going to be critical going forward in the future. AHRQ is a treasure chest filled with evidence and evidence-based tools. We must develop new and innovative partnerships to ensure that more health systems, doctors, nurses, patients, and communities are using them. The potential return on investment is extraordinarily high and can indeed create value much larger based upon the work that we already have done, as well as create potential benefit to American patients. We need innovative ways to exponentially increase the uptake and spread of our work, and understand how we can do that. Finally, as we will talk later this morning, AHRQ is committed to identifying the unmet needs within health systems and make it difficult for them to become learning health systems. Today, there are many barriers to make that learning health organizations happen, and I believe we can help catalyze that environment and help build that ecosystem. My vision for AHRQ leverages our core competencies, the research and implementation around quality, safety, and data and analytics capabilities, combined with our nimbleness and staff expertise to create what I call an AHRQ version 2.0. This would position us to address the key questions of today and the questions of tomorrow to improve health and healthcare of Americans. I look forward to working with you to identify the important questions we should be asking and identify the most important areas where AHRQ can have the greatest impact. I thank you for your service to this agency and to the American people. I would like to turn over to Sharon to update us on our work and recent developments. At the end of the presentation, I would like to get your input and will be pleased to answer your questions that you may have. One of the key things that's on my mind is you can help us understand from your vantage point where we can have the greatest impact, particularly how we leverage our work and create the opportunities of a multiplier effect of the value proposition that we create for our physicians, for our clinicians, and for our patients. So with that, I'll turn over to Sharon, and please take it from here.
Okay. Thank you very much, Gopal. Let's see if I can. Okay, so I just want to orient you to the agenda today. You just heard Director's vision, and I'm going to update you on the activities since the last NAC meeting. We'll have a presentation on where we are on our vision of the learning health system, the activities we've done, and what's coming up, and then we'll break for lunch. After lunch, we're going to have an update on Evidence Now. We've got some findings coming out of that big project now, and we're really excited to share them with you. Then we'll have a session on AHRQ data and analytics to address emerging issues, and we hope this is a good discussion about how we bring together the analytics we have kind of throughout AHRQ and think about how to kind of match it up for emerging issues going forward, and then a wrap up and discussion. So a busy day ahead of us. So let's see. We have updates for our members. As you've heard from the introductions, Lucy Savitz is now the director of the Kaiser Permanente Center for Health Research in the Northwest, and Christine Calamero is a senior nurse scientist and the director of research for nursing and evidence-based practice at Children's Healthcare of Atlanta. Congratulations to them both. We have two new ex officio members. Mike Lauer, who's the Deputy Director for Extramural Research at NIH, is our new NIH representative, and unfortunately Mike had a family emergency early this morning and so was unable to join us today, but we look forward to having him participate in future meetings. And Chesley Richards, who's the Deputy Director of the Public Health Scientific Services at the Centers for Disease Control and Prevention, is our new representative from CDC. And I think Chesley is supposed to be here today, so hopefully we'll look forward to seeing him during the meeting today. So first I want to give you an outline of the President's budget proposal for AHRQ. This is the FY 2018 budget proposal. As you may have seen, it provides $378.5 million in discretionary funding, an 18% reduction over current budget. It also folds AHRQ into the National Institutes of Health as the National Institute for Research on Safety and Quality, or NERSC. Doesn't fall off your tongue very easily, but I think the important thing is the proposal is to keep us intact as an institute, which we saw as a very positive thing. The budget retained a number of major and very important programs from our perspective: the investigator-initiated research, patient safety, evidence-based practice centers, our data GEMS, MEPS, and HCUP, and also our support for the U.S. Preventive Services Task Force. However, it also eliminated a number of very important programs, including our health information technology line item, the quality indicators work we've done in the past, our research on CAPS, the data analytics support, and all dissemination and implementation contracts we currently have. So a significant change from our current operations. Moving on to past activities, AHRQ had a very robust presentation at the Academy Health meeting. We were very pleased to participate in 18 podium presentations and 32 posters, which I think is a high for us, and you can see the range of topics that AHRQ staff were presenting on. So it was a very exciting time for us, and we were very pleased to be participating in such a big way at the Preeminent Health Services Research Conference. I think you have in your folders, we had presented to you last time our very first pamphlet called AHRQ, and we've just produced another one, which is really exciting. This one is on physician burnout. So we're trying to produce kind of synopses of our research in a very user-friendly way, and we would love your thoughts on whether this is an effective model for disseminating our work, and if you have any ideas or suggestions of AHRQ work that we should talk about in this way. So now I'll go through kind of our core activities. This is the slide that reminds you that we do kind of 3 types of activities. We invest in research and evidence, we create materials to teach and train, and we also generate measures and data. So we have recently produced an analysis in pediatric that looked at sensory interventions to improve autism behaviors, and this research found that sensory-focused interventions actually do reduce impairments in children with autism spectrum disorder, but there was little evidence to support diet interventions. The U.S. Preventive Services Task Force has been quite busy since the last meeting. You can see here the range of final recommendations, and on the next slide, the draft recommendations that have been posted for public comment. So they continue to just kind of push forward with incredible energy on a wide range of topics, and we do everything we can to support that. The evidence-based practice centers have also been incredibly busy. We have a number of systematic review updates and new systematic reviews and technical briefs. You can see the range of topics up there, and a number of methods reports on the next slide. So very busy set of activities as well, and we'd be happy to discuss any of those with you in more detail if you like. Tools and training. We continue to report on the National Scorecard on Rates of Hospital-Acquired Conditions. This is an update for an additional year of evidence, and the decline in HACs continues, which is very heartening, and more reductions in hospital-acquired conditions and more potential cost savings from that. This shows you the actual kind of reductions in the activities, and you can see that we're making really good progress here. We've also just reported on a drop in healthcare-associated infections among nursing home patients. So this is an application of our well-known CUSP methodology to healthcare-associated infections in nursing home patients, and we've seen that CAUTI rates drop significantly as a result of this intervention, and 75% of facilities showed a reduction of at least 40%. This is really tremendous progress from one intervention, and we're very gratified to see this and look forward to working with partners to disseminate this further. We have a new recent funding opportunity announcement for the National Research Service Awards Institutional Research Training Grants at T32. So that's up for recompetition. We're looking forward to seeing the applications that come in as a result of that and continuing that great program. So we have a lot of data work that has been published recently. So for those of you that don't know, the Medical Expenditure Panel Survey Insurance Component is an annual survey of private employers and state and local governments. And we've recently released estimates from the 2016 MEPS-IC for private sector establishments, and also released a statistical brief with the following highlighted findings. So with respect to enrollment in employer-sponsored insurance, there was no significant decline in the percentage of employees covered or in the number of enrollees. Premium growth rates remained low from 2015 to 2016. These growth rates for single premiums and Employee Plus One were similar to the growth rates from 2014 to 2015 and lower than the growth rate for family premiums for 2014 to 2015. There was no statistically significant change in the percentage of employees working at establishments that offer insurance between 2015 and 2016. This is often called the offer rate. However, the offer rate at medium-sized employers increased from 85% to 88% in this period. Offer rates at small firms were unchanged between 2015 and 2016. And the overall take-up rate declined from 75% in 2015 to 73% in 2016, the lowest level in the 2008 through 2016 period. So from 2015 to 2016, there was no significant change in the overall percentage of private sector employees covered by a health insurance plan offered by their employers, or the enrollment rate, and no significant change in the enrollment rates at small, medium-sized, or large firms. In 2016, 47% of employees were enrolled in a health plan through their employer, 26% at small employers, 45% at medium-sized employers, and 56% at large employers. Enrollment rates were lower at smaller employers than at large employers throughout the 2008 to 2016 time period, mainly due to lower offer rates at small employers. The 2015 to 2016 growth rates for single premiums and Employee Plus One premiums were similar to the growth rates from 2014 to 2015. The 2015 to 2016 growth rates for family premiums were lower than the growth rate for 2014 to 2015. The 2015 to 16 growth rates for single, Employee Plus One coverage, and family coverage were among the lowest growth rates in the entire period from 2009 through 2016 for each type of coverage. And this is pretty dramatic. Okay. We've also done some work on the medical care costs of childhood. Oh, yes. Yeah.
Just a quick question about
Yeah.
that. So the premiums were flat, but what happened to the other structural aspects of the plans? Are deductibles up? You can keep premiums flat by increasing, risk sharing. Were there any changes in that?
Joel, are you?
Yeah.
Yeah.
Yes, those have been increasing over time.
Right.
So you're saying those are being increasing
Those
over
are
time?
Yeah. I believe, I'm not sure if that's in the staff brief.
Come over here.
Come sit here, Joel. In the hot seat.
Yeah, really. I'm not sure if it's in that particular stat brief, but we do have a chart book coming out in another month or so that's going to have a lot more detail about what's going on, and you'll see that those, the cost sharing is certainly increasing on employer-sponsored plans as well. So.
Hopefully it'll come out in the next month, not or so, because then I can use it in my fall course.
Yes. Good. That's great. Yes, it's supposed to come out within the next month. Absolutely.
But I don't think we see a dramatic spike, right?
No, it's not a spike.
It's
It's
a
been
continuation of
a continuation of a trend over time. Yeah.
Yeah. Thank you.
Sure.
So we've also done some work on childhood obesity, which is of particular interest to the Secretary. And what we find is that being obese during childhood is associated with significant short-term medical costs, and that they're larger than have been previously estimated using these new methods that have been developed. So the costs of childhood obesity are borne almost entirely by third-party payers, which is consistent with the substantial externalities of youth obesity. So here are some of the results. So obesity raises medical care costs by 128% among boys and 200% among girls, and severe obesity raises medical care costs by 250% among boys and almost 400% among girls. Quite a dramatic increase. Among children with private health insurance, severe obesity is associated with a greater increase in third-party payments among boys, over 400%, than girls, only about 300%. This is because the cost of severely obese boys are greater than that for girls, while the expenditures for healthy weight boys and girls are similar. Among children with public health insurance, obesity raises public health insurance expenditures by about 300% for girls compared to about average for boys, about 100% for boys, and severe obesity raises them over 600% for girls compared to 170% for boys.
So Sharon, do
Yeah.
you have a sense of why the sort of relationships there for severe obesity are so different between private and public?
I do not know. Joel is. Yeah.
Joel, hot seat.
Yeah.
Yeah, that one I'm not quite sure about, but it probably has, it could have something to do with the different populations under the private and public insurance. So I'd have to ask Adam Beener, who was the one who did this research. But I think there's probably, in terms of health status across those populations, I think in general the publicly insured are less healthy in general than the privately insured. So you could see where the effect of obesity might be greater.
It was just the gender differences that flipped dramatically between private and public. So that's I just was not clear on what was driving that. But.
There are some recent papers looking at toxic stress in that population just because of poverty and the effect on obesity that I think are fairly dramatic. So my whole thing is we can see those numbers, but taking a step back to see what are we really doing about the issues many of those children face.
Right.
Growing up. I think that's what we need to target personally.
Yes.
So I think we're done with the maps. Joel is out of the hot seat. We'll get Pam up next if we have any questions on the HCAP analyses. So we have been also doing some work on opioid-related hospital stays using HCAP. And we released a recent brief that showed that hospitalizations involving opioid pain relievers, including heroin, is up 75% between 2005 and 2014. And this significantly outpaced the 55% rise in hospitalizations for men. So for women, it's much higher than for men. But now the rates are virtually the same for men and women. So we've had a catch up for women. There are significant variations by state. West Virginia, Maryland, and Massachusetts had the highest rates of hospitalizations, more than 350 per 1,000 people, and lowest rates in Nebraska and Iowa. So we also have a tool called the HCUP Fast Stats. So the HCUP data combines the data from all the states into a national file, but we get the data from states at a differential rate. And so for those states where we get data faster and we have their permission, we actually put up the state-based data much more quickly. And so we have much more rapid data on what's happening. So here we see trends over time. It's a little hard to see that we can see the most recent data through the third quarter of 2016, and you can see steadily increasing rates of opioid-related inpatient stays. We also see a jump in opioid-related inpatient stays with the introduction of ICD-10. So this raises a question of whether we've been undercounting opioid stays or just a measurement issue that we are looking into more closely. But it's really kind of interesting to see this change over time, and we can see it almost in real time with this data, which is really neat. And we have
Sharon, just one thing. Given what you just said about the apparent effect of ICD-10, I think it's going to be really important in reports, along with what the director was saying about improving the way that we disseminate information, to make that clear on any charts, and also to look for that for other things, because we all know ICD-10 is so much more granular, maybe too granular. But I think that's going to be really important, because most people just look at a picture and never read the things that go with it.
Yes, absolutely. I mean, we're trying to look to see the effect of that change in coding on some of the other work we do, and trying to understand at a more granular level kind of what's causing it. Are there certain diagnoses that are differentially affected, et cetera.
And Sharon, just with some of the work we've done in the High Value Healthcare Collaborative, this is a huge issue. And we've done some recent work at Kaiser Northwest looking at low value care. And you're seeing these just sort of disparities in the data that don't make any sense.
Great. Yeah, I mean, we can kind of report back at a future NAC meeting further analysis that we're doing on this. It is something that we're looking into quite seriously. So we're not as far along as we would like, but the data is very fresh at this point. So, okay. The HCUP data, the FAST stats also shows the response to policy changes. So this is just an illustration of policy change. So the graph on the left shows all stays by payers in Illinois. We see a shift down in uninsured and a shift up in Medicaid-covered stays at the beginning of 2014, which we've reported on previously. On the right, we focus on mental health and substance abuse stays, and we see a decline in Medicaid-covered stays at the beginning of the third quarter of 2012 and a jump back up in 2014. So in 2012, Illinois implemented Medicaid budget cuts. One area completely eliminated was adult detox services in the hospital. Not until the Medicaid expansion did we see a rebound in Medicaid-covered mental health and substance abuse stays. So this data is really powerful to kind of track the impact of some of these policy changes as well. Just another illustration of what we can do with this data. And we have another recent HCUP brief that provides a recent overview of hospital stays. And these are hospital stays in short-term acute care hospitals. And we find that inflation-adjusted costs per stay increased about 13% over a 10-year period. Most of that increase was in Medicaid and private insured stays. No real change in cost per stay for Medicare-covered patients and the uninsured. Mental health and substance abuse-related stays increased 20% over this 10-year period, and all other service lines remained stable. Septicemia, or sepsis, nearly tripled over 10 years. It's now the most common reason for hospitalization besides giving birth or being born. We're following up on this finding with another stat brief to be released later this year. Sure.
So I'm particularly interested in the septicemia data because I'm on the NQF infectious disease panel that looks at measures. And there seems to be some credible evidence that this is in part a result of coding the Surviving Sepsis campaign and increased vigilance on detecting milder cases, inflating the denominator, making it look like we're saving more lives than we are. Will you be able to take a look at that and perhaps reflect on how that may reinterpret some of these findings?
So we can certainly take a look at it. When we publish our stat briefs are kind of just the facts as we see them. So we tend not to do any kind of policy interpretation in the stat briefs, but we can certainly consider doing a longer article on, a journal publication on kind of the reasons for the change. But, we're constrained in that one vehicle, but we can certainly take a look at the reasons behind it.
Given all the constraints, this has been largely interpreted as being a national crisis.
Right.
Opioids is a national crisis. I don't think a epidemic, sudden rise in people falling over in the street due to sepsis is. Okay. So it's obviously an important issue to deal with. It's always been, but I don't think it's rampant and on a rampage.
David?
I'm wondering if you've done any state-level analyses of different policies around opioid use. I know some states are imposing sort of maximum dose limits and prescribing, and there's a range of sort of policy changes at the state level, and it'd be interesting to see whether that's leading to benefits. There's some concerns that it may actually lead patients to go seek illicit sources of drugs. So trying to see those kinds of changes. And the other, does the HCUP data allow one to distinguish hospital use due to prescribed opioids versus street drugs? Because the concern is that if patients are not getting the drugs through their clinician, they may be getting, moving to heroin.
Yeah. So For your first comment about whether we're considering looking at state policy impacts on HCUP data, it is something we're considering going forward. So we think that that's a kind of a ripe area for research going forward, and is something under consideration, kind of resource constraints, taking into consideration resource constraints. I don't think our data allows us to distinguish between prescribed versus illicit, although somebody there can correct me, Pam? So it's all based on... Yeah.
Thank you. We're solely dependent on ICD-9 and ICD-10 codes. So ICD-9 codes were more constrained, so you could see opioid overuse, opioid dependence. You can see heroin in there. In terms of whether it was prescribed opioid or street drugs, that differentiation is not made in ICD-9. ICD-10 actually provides more specification on opioids. There is an article under review right now that's going through what some of those codes are and how that translates to ICD-10. However, it still doesn't get at your point, which is this a prescription drug or is this not a prescription drug?
And for those of you that don't know her, that's Pam Owens, and she's a senior scientist in our Center for Delivery Organization and Markets, and obviously expert in this area. Thank you, Pam. Okay. So now I'll open it up for further questions and discussion, both on kind of what we've been doing to date and Gopal's earlier remarks on the vision for AHRQ going forward.
Monica?
If we could go back to one of the earlier slides that discussed the proposal of AHRQ being converted into an NIH institute, and talk a little bit more about what that means for shifting priorities within the organization. And so I know that you had talked about your vision, but in particular, are there things that AHRQ has historically done that will no longer be part of this vision? I know that there have been some budgetary cuts, but there are difference between cutting because you have to for budget and then cutting because it's no longer part of your sort of mission. Where do you all see the organization going with a transition, and how firm or fixed is this transition? Is this going to happen? Is it just proposed at this state? Where are we in that?
Looks like 3 questions, so
Sorry.
let me start with the last one. It's part of the president's proposed budget. The second piece, in terms of becoming part of NIH, the key over there is that the president proposes that AHRQ stays whole, complete as it is. And your third question about priorities, I think we had a slide earlier on which says what our mission critical focus will be, as well as some line items that we'll not be able to address because of the budget cuts. Mm-hmm. So the overall impact in terms of the vision is twofold. One is we'll have to rethink our priorities in terms of, again, the mission focus stays as we discussed. But the other things that I talk about is how do we take advantage of some marginal investment opportunities to improve the uptake and use of evidence and make it broader. We already have a treasure chest of assets that we have worked on. So there might be some opportunities to do that. I think there'll also be opportunities for us to take a new view on the data interoperability piece, how we can get more data access from the federal agencies and other entities to have a broader view as more and more data is available. So there's a lot we can do given the president's proposed budget moving forward. And of course, the third one is that is important to the council and has been talked about earlier is the learning health organization, learning health system. And I believe that AHRQ can continue to play a key role in being a catalyst in that area. So, of course, budget cuts anytime have an impact, but I think so we are well positioned to do the very best given the president's proposal.
But I do think it's worth noting that, of course, Congress has the final say on budgets and organizational changes. And at least the bills that are moving through the Congress don't seem to include moving AHRQ into the NIH. And while I think there are reductions in the budget, and I don't recall now what the Senate mark is. And actually, Lucy, you probably have more recent information on this through the work you do on with Academy Health.
Well, I think the agency director is probably the most up-to-date information on it, but our sense is that they're no longer really talking about folding into NIH, and holding the agency whole, but with a fairly significant budget cut.
So let's see, I saw Don and then Sandy and then David. Oh, no? Oh, Lucy, sorry. I called on you and then she was, exactly. She'll learn, she will learn. So, well, as long as you have the mic, why don't you just continue?
I just had a question. So some of the work I've been doing over the last couple of years has been looking at social determinants. And we know the ASPE report came out in December saying that there really is a high need. And while not perfect, some of these neighborhood measures of social determinants are fairly inexpensive to calculate at the census block level with census data. And I'm just wondering if you've thought about incorporating that into some of the HCUP data so that we can begin to look at it on a more national level.
So we've actually been thinking about using social determinants of health on a kind of number of aspects, and we'll talk about this more, or we could talk about this more this afternoon when we talk about our data resources. But we have been thinking about adding a social determinants set of questions to MAPS to kind of add some depth into the analysis we can do. For MAPS, we've been thinking about kind of adding those variables, merging them into HCUP. And we've also been looking at kind of merging that kind of data, thinking about collecting that kind of data and potentially merging it with clinical data through the electronic health record. So we've been exploring all three avenues and would love your feedback as to which one would be.
Well, I can send you our papers that have come out on this topic, but the University of Wisconsin, the last time they updated the area deprivation index for the nation was in 2013, and then we've done at Intermountain, I'm no longer there, but we've done more recent updates, and we're working on it at Kaiser Northwest, and it's very simple to do, so you're not needing to ask any questions, and we're finding that it's holding up pretty well.
Really?
Yeah, and there's a lot of stability over time, and if you live in a low ADI area, you tend to stay in that social circumstance beyond, a 1 year period.
Good. Don?
Well, first of all, congratulations, Gopal, on your new role, and thank you for inspiring vision. And Sharon, just a special note of thanks to you for serving in interim capacities and always being a stalwart advocate for AHRQ and its good work. So thank you. I don't know if these are questions or philosophical ruminations, but here goes. There is a definite tension among agencies as to who's doing what and who holds what data and who has what work to do. And I think this gets reflected in some of the commentary about the future of AHRQ by policymakers and pundits in the country. And so given that, the clarity of vision needs to encompass in some way how these relationships unfold and where the collaboration is. I've lived long enough to see many HHS efforts that are supposed to integrate across all agencies sort of do it for a little while and then it kind of goes back to the usual state. So with that in mind, there were 4 areas that I thought we might want to at least think about, sort of questions about the future. The first has to do with the vision that we're going to deal with the burden on primary care and focus on primary care and effective care in general. One of the things that where I work, IHI, we don't do well at is to think about the future of technology and informatics, and to some extent data analytics, but mainly tech and IT. And my own view is improvement in implementation science are very unlikely to be effective in a very rapidly changing environment of technology. So it's a little discouraging to see HIT on somebody's hit list. Maybe somebody else is doing that, but I don't think transformation of primary care is possible without a better dialogue with technology and informatics. Secondly, the issue of data sources. And I think you, Gopal, can I call you Gopal, not the director?
I prefer that.
Good. I don't know, it's public because somebody's recording it. I don't want to do the wrong thing. You know, the only way a student can fail my courses is to call me professor or doctor more than twice. It's especially hard in some cultures to do that. So the second has to do with these data sources. And this is a challenge for health services research in general. And I'm on the board of Academy Health, and we're constantly thinking, what does the future of health services research look like? A lot of the research is not going to be hypothesis driven in the way we're used to, and it's not going to use the usual data sources. So certainly DeepMind and IBM Watson don't think that way. Data mining and genomic epidemiology are thinking in different ways. And so AHRQ asking itself, well, what is our connection to truly advanced data analytics? And again, that was somehow on that hit list, which it seems bizarre to me, but nonetheless. So that's the second. So the first, technology and IT, the second, data analytics. The third is this kind of almost bipolar attitude in the United States about studying cost. So clearly you've presented data on cost, but when we get to cost effectiveness, it seems to somehow be taboo. Certainly it was almost a death experience for Pecori to have to think about cost. And we just completed a survey, actually Harkness Fellow works with me, just completed a survey of state legislators, both Republican and Democratic, and they clearly agree on only one thing, and that's cost for payers and cost for people. And so in this environment where there's bipartisan agreement that costs are important, having a clearly enunciated vision about how AHRQ will deal with not just effectiveness, but with cost effectiveness seems important given the continuing problems we have with cost of health and healthcare in America. And then fourth is something to reflect about. We obviously have a crisis in opioids. My personal feeling is a national crisis. It's interesting to me, a national crisis involving Black people and Hispanic people don't get the same level of attention, but nonetheless it is a crisis. The question for not just AHRQ, but for HHS and for Secretary Price is this going to be a one-off brute force where all hands on deck, it's sort of HIV-like compressed in time, or is it going to be used as a way to really look at systems that we have to promote health and improve health care in America, especially for disadvantaged populations or people living in poverty or in rural areas? How can AHRQ, through its discretionary research funding, look at how this reveals issues and problems in the systems beyond just dealing with opioids per se? My biggest fear is that we will, and I know we will, solve this problem. There will be steep reductions in there already are reductions in opioid prescriptions. The rest will follow over the next half decade. But what will this do to improve primary care, to reduce burden on clinicians, to improve the health of the population, all those things we're talking about, as opposed to dealing with a segment of the problem. So I guess that's a lot to say, those four areas, but I think they do help illuminate how AHRQ can leap into the future. You know, when you have core competencies, the danger is that they become the pillars of your work, and there's a tendency to, we're really good at this, we'll continue to be good at this. The future is going to demand of AHRQ that it not just look like it did look, but to leverage those competencies, as you said. But it's a leap. It truly is a leap. As for incorporating in NIH, I know that will come back up, even though it's not going to happen for sure, I think, this year. And the question there is, there's also part of that budgetary request that looks at the overall funding and research in health services research specifically. So we have this enormous dissemination implementation portfolio of work at NIH. In some, like NCI, it's very, very important. In others, they don't even know what it is. But that's going to be the tension. And although keeping AHRQ whole is probably going to be what happens, if implementation research and the translational pathway is still a competition among powerful agencies who are going to cure something, will the AHRQ really maintain its preeminence in health service research? So that is my editorial. You're free to quote or attribute.
Don, I just want to kind of respond to that last comment by saying that the president's budget had a line item in it for a study, a trans NIH study to look at health services research across NIH, including AHRQ. The House mark actually had a similar provision in it. So we were very happy to see that carried through. So it would be really nice to have an independent study of health services research kind of throughout the NIH institutes, including AHRQ, and a recommendation going forward for how that should be coordinated. I think that would help.
Yeah, I think I famously said at the time that it was one provision of the budget that I was enthusiastic about. Whether it's the only one or not, I'll leave that private, but it was one.
And may I call you Don? No. I agree with your passion. I think data is going to be key, and I think so there are things that we need to look at and see how data can help us leapfrog. And one of the visions I have is that ultimately I see a AHRQ Insight or data analytics enterprise level platform emerging over a period of time. I think we have great opportunities with that, and we have tremendous leadership in that area. The other comment about opioid, you're right, and that's the reason why the secretary is concerned not just about opioid crisis, but also mental health as well as childhood obesity. And he's looking at on a much larger scale. His view is, so you're absolutely right. So your thoughts are well taken, that we'll have to examine ourselves and see how we position ourselves for the future as opposed to perpetuating what we've done in the past. That point is well taken, sir.
Yeah, first, I also want to congratulate you and welcome you and wish you the best of luck. And Sharon, thank you and the rest of the staff for a terrific job that you've done through all these transitions and everything in the last couple of years. I just, my questions really parallel a couple of the things that Don raised in light of your vision and where you'd like to take the agency with the focus on information. Well, you know, I think it was T.S. Eliot who said, where's the knowledge we lost? So, I'm going to garble this in some way, but where's the knowledge we lost in information? Where's the information we lost from data? So, you know, how do you translate data into information? And then, as was discussed earlier with in the disparities group, and I guess a little later, how does that information help be leveraged for action, you know, that it can be acted upon when appropriate? And I just wanted your thoughts a little bit about, given the proposal to eliminate health information technology and data analytics and how core elements of those programs, the way they're structured, are to your vision, do you see that there are aspects of those programs that can be repurposed for the patient safety aspects of it? Or it just seems hard with that. It seems to me those are core to what your vision is, the analytics, at least components of the analytics in the health information technology programs.
Two questions. Coming to the reduction of HIT budget, I think we'll have to go back and rethink ourselves, and we are doing that right now as an agency and with our team to see how we can repurpose and recalibrate our work to be able to pursue the data interoperability vision for the long haul. And coming back to your earlier comment, again, I would say that we'll have to find innovative ways, not just to build and envision the platform, but also look for those opportunities where our knowledge on use of evidence can be exponentially increased. And I believe that's where you can help us to identify where those opportunities exist, where our work can be leveraged for uptake as well as a much broader use of evidence at the point of care. I believe the fact that AHRQ has this very broad base working with the primary care physicians, clinicians, gives us a huge advantage from an HHS perspective, because we can take the work done by NIH and move it much faster. So we really are the bridge between research and implementation. And I think that's where your ideas and thoughts would be extremely important to us.
Thank you. That's very helpful. Along those lines, and it's been mentioned by others, I think the implementation science is a useful framework to sort of make that appear more coherent to people outside the field and inside the field. I think elements of that might be a useful framework for articulating some of that, with the idea that it's science, but it's implementation focused, which is, a bit different than, some of the more basic types of research that, for example, NIH focuses most of its efforts on. And clearly, the ultimate goal is implementation, but it's mostly a basic science enterprise.
Just to follow up to the prior comment, I serve as the chair of the Committee on Advocacy for Public Policy for Academy Health, and we proposed to the board, and at the June meeting, they approved us commissioning a special report that will be convened by the National Academy of Medicine to look at the future of health services research. And I'm sure you've spoken with Lisa Simpson about being engaged in that effort.
Yeah, and that meeting that's going forward, right? Because there's an October meeting. Yeah, so I think I'm echoing others. We're undergoing a similar exercise in VA health services research to try to grapple with what's the role for research relative to all the other, what I call small R research that happens in a healthcare system and through the private sector. And one way of thinking of it is what won't have a home anywhere else. And it seems that especially if the secretary is interested in physician burden, the whole issue of how big data and HIT impact the delivery of care is a big component of physician burden. And I think that I certainly don't trust the private sector to get everything right as they think about approaching big data. So one important part of the agency is, and especially for health services research, is to think, how do all the innovations in both informatics, in data mining, in bringing data together actually translate into decision making at the level of the clinician and the patient. I'm afraid that's a place that's no one's going to own. Certainly NIH isn't going to own it because it cuts across too many different institutes. I don't think the private sector is necessarily going to own it because they'll be thinking about selling their products. And it's certainly something that I think a lot of your stakeholders would care about if people can bring some objective research into that. I think one role for agencies is to be a dampening effect on the sort of swings of hype that come with any new innovation.
In my long-winded remarks, I forgot to mention training. And it's really gratifying to see continuation of the NRSA 232 program as a holder of one of those now for over 20 years. I think it's been extremely valuable in populating the pediatric community with people who know how to do health services research. That said, what that training is going to look like in the future is a challenge, especially when we consider the importance of not only being able to interpret and utilize data, but how to really understand implementation science. And the current RFP that's on the street is very similar almost identical really to what it's been in the past. And I know that the agency is thinking about ways to fund, especially junior faculty, in implementation and in healthcare delivery systems and in implementation. The challenge there is going to be how do we do that without losing fellowship? If you go through, let's say, Lucy's organization, you put a fellow in there and they study implementation, and they're not part of a cohort in which people learn from each other, PhDs and MDs and people who are nurses and people who are physicians or physiotherapists. How do you maintain that? So it's something I'm sure you'll be thinking about it, but it's a probably unique opportunity for this agency to promote that kind of research skill set. In addition, and this is as much Academy Health's role as it is AHRQ's role, maybe more Academy Health's role, the places in which people are going to end up doing this research are changing pretty quickly. And it's not just academia anymore. It's going to be in large health systems, going to be in payers, going to be in industry, and kind of partnering in ways that make that acceptable is going to be important. It's not just becoming a Professor Brown anymore.
So, Don, I think we've talked about this before, but we have been working to identify the competencies required for kind of a new generation of health services researchers that work in systems of care, and have been working with PCORI to conceptualize a training program that would have both academic components and components of being placed in health systems. So we're hoping to have an FOA out on the street shortly, and can't say any more about that because it'll be a competitive FOA. But it is something that we have been working on and are very interested in pursuing.
Yeah, you might, this is just a wild idea. I'm an EIS officer, and the EIS had a way of placing people in different areas, but maintaining the sense that once an EIS officer, always an EIS. I'm sure I can go to any EIS officer anywhere in the world and say, I'm Don Goldman, I'm an EIS officer, and that'll be a recognizable bond. So there are these kinds of cohort enablers that I think are really important.
Okay. I think we will move on to the next session, which is an update on the learning healthcare system work. So I'll ask David and Bridget to join us at the table and briefly introduce them. David Myers is a board-certified family physician who is AHRQ's chief medical officer, and among the many things he does, he is participating in the strategic planning around the learning health system work that AHRQ is doing. And then Bridget Russell is the senior advisor in the Office of the Director, and she's co-leading the development and implementation of AHRQ's activities related to the learning health system. And then Jamie Zimmerman, you all know well, is also working on a variety of special projects, including the work around the learning health system. So without further ado, David, Bridget, and Jamie, I'll turn it to you. And trust me, we will give you your full time, despite the fact that it looks like we ate into the beginning of it. We'll make it up by denying lunch to the advisory council.
Well, this is really for all of you, and thank you for inviting us back. In your November meeting, we spent, and you just ratified the minutes, so I'm sure you all remember all the detailed discussion and advice you gave us. We came to you with our director at the time, Andy Beinman, and said, is this a place AHRQ should go? And we heard from you very loudly, yes. And so we wanted to update you on what we've done with that feedback. So this is going to be a quick update, and one of the best things about getting to work with Gopal and Sharon in the Office of the Director as the Chief Medical Officer is getting to work across AHRQ and see the amazing ideas and people behind them throughout the agency, and the chance to work with Bridget and Jamie on this initiative has been one of the highlights of my year so far. So this is sort of a rough timeline and an outline of what we're going to share with you today. It's the reminder that this came from you all as a charge to us to pursue the idea of what could AHRQ do to catalyze movement towards learning healthcare systems, learning health organizations. So the first thing was figure out a name for it. And then, so we went and we requested from the public feedback, and we're going to give you an update about our request and what we learned from that. Then I'm going to highlight 4 programs that we are currently working on that fill out this vision right now. And then I'm going to turn it over to Jamie to talk about some of the activities to bring the community together and where we think we're going with this. So as a reminder, this is AHRQ's diagram of a learning health system. It's a delivery system. It's the place where patients and the healthcare team come together to deliver health and healthcare. It starts there with the generation of information about what happened to those people. Patient-reported outcomes and clinical data gets generated all the time in a healthcare system. And right now, that's just been sitting there. And so the learning healthcare system paradigm says we move forward, we take that information, that data, and we turn it into knowledge about what's happening in a healthcare system locally, small systems like offices, larger systems, healthcare delivery systems, and even as a nation. And then most critically, we take that information along with what we're learning outside of the healthcare system. So it's combining both locally created evidence and with gathering evidence from outside the system, and as I was about to say, most importantly, applying that evidence into practice back at the point of care. And we see AHRQ has a role in all of these steps, helping evidence be used in practice, helping turn the practice data into knowledge. But specifically, we have a unique role in helping healthcare systems translate what they've learned into practice. Because just knowing, as you all know, doesn't create doing. So making evidence usable, and that's what we see as a unique value that AHRQ is going to bring to this. So we went out to the larger national community and said, do you agree with our National Advisory Committee this is a place we should go? And if so, what are you doing? And what do you want us to do? Here's what we learned.
Great, thank you, David. So in January, AHRQ released this request for information to better understand the process by which organizations and professionals select evidence to implement and the strategies they use to move this evidence into everyday practice. The RFI contained 11 specific questions. The 4 here provide a good overview. So we inquired about how systems use their own data to inform practice, the types of metrics they're using to evaluate system performance and progress. We wanted to know how they're involving patients and families in their efforts. And then perhaps most importantly for AHRQ, we wanted to know ideas that how AHRQ could support healthcare delivery organizations in their transformation to becoming learning healthcare systems. The RFI was open for about 6 weeks, and we received a robust response of 44 submissions from a variety of stakeholders. These stakeholders included researchers, many of whom are also physicians, health systems, academic health centers, and professional associations. The respondents were overwhelmingly supportive of AHRQ moving forward to support learning healthcare systems. I'm going to focus on the recommendations for how AHRQ can assist in this transformation. Responses kind of convened around 4 main themes that are going to be very familiar to you because they align nicely with how we think about AHRQ's work. So there were an overwhelming number of suggestions related to data and analytics. A common idea is to further refine and promote AHRQ's existing data resources to support health system benchmarking. One suggestion was that we could provide updated CAHPS and HCAHP metrics that allow for assessment beyond the most recent 12 months. Respondents also asked AHRQ to develop and maintain large comparator data sets and provide access to data networks. And this is particularly important for some smaller organizations that have a limited ability to invest in infrastructure. Respondents also wanted assistance in managing their own large data sets, particularly ones that combine data from multiple sources. Specific needs here included support for development and validation of predictive analytics, tools that facilitate integration and connection to population health data, and promotion of data sharing among institutions. And finally, respondents asked that AHRQ work to establish a preferred set of measurement and analytic approaches so that there would be a more uniform approach to learning healthcare system research. There were a number of suggestions made regarding further development of models and metrics. Some common ideas included models of accountable care organizations that could be replicated in the field, measures of system improvement that reflect the use of data, new measures around low-value care to support de-implementation, and quality measures to support the diagnostic process. And as always, it was suggested that AHRQ could help in aligning measures to reduce burden and also working with health systems to test measures in the field before federal implementation. Regarding tools, AHRQ could work to modify existing tools to better support learning health system practice. One tool that was specifically mentioned was AHRQ's Care Model Toolkit and Dissemination Planning Toolkit. AHRQ could also work to develop a toolkit to support rapid, rigorous, pragmatic trials. It was suggested that AHRQ could catalyze research being done by the NIH Healthcare Systems Research Collaboratory and the developing NIH VA DoD Collaboratory. And finally, again, AHRQ could work to develop tools to decrease the delivery of low-value care. In regards to training, there was support for continued training and professional development for both health services researchers and healthcare professionals. It was suggested that AHRQ invest in training that provides the bridge between academic institutions and delivery systems. And you'll hear more about our plans to train researchers in the core competencies of learning health systems, which is in line with this request. It was suggested that AHRQ provide training on research methods and data to health practitioners. Specifically, practitioners would benefit from data science techniques to better analyze, predict, and evaluate system performance, clinical outcomes, and service delivery. There were several suggestions relating to dissemination and implementation. AHRQ could work to identify the most effective approaches for diffusion of best practices, and folks here were particularly interested in learning how to tailor these tactics to meet their own specific environment. AHRQ could also work to refine existing practice transformation methodologies for supporting system-level change. And AHRQ could develop and disseminate case studies of other health systems' experiences as learning healthcare systems. A couple of specific ideas here for the case studies included how systems are structured to support learning and the use of data visualization as a performance improvement tactic, especially if they're comparing their own local data against AHRQ data sources. There was almost universal recognition of AHRQ's role as a convener of disparate stakeholders to promote collaboration and catalyze action. Responders asked for AHRQ to bring together nonprofit, government, and industry representatives to underscore the importance of evidence-informed practice and practice-informed evidence. It was suggested that AHRQ create mechanisms through which systems can collaborate with and learn from their peers, such as convening a learning collaborative focused on accelerating the development of learning health system capabilities within healthcare delivery systems. Finally, respondents suggested that AHRQ could provide assistance in implementing IHI-like programs to assist hospitals in evaluating their system and implementing culture-changing strategies. And with that, I'll turn it back to David, who's going to talk about some of our current efforts.
Actually, if it's okay, do you want to do a quick questions for Bridget on that before you hear where we're going? Or do you want to hear the whole thing and then questions? Either way is fine.
It was nice to see some of the comments I made for HVAC.
I should have mentioned thanks to you all for responding to our request.
Okay, so we'll just move forward. We'll push forward. So we listened to you. We're listening to the public. We're going to talk about now how we're going to, in a moment, how we're going to get even more focused specifically on what we can do. But this being AHRQ, we weren't going to wait for the entire year of strategic planning to get started. So we've been thinking about how some of our large efforts already can be tailored to move this vision forward. And I'm just going to highlight 4 examples of that. The first you've already heard about is in enhancing the workforce able to do this work. And specifically, AHRQ went out and has developed competencies for health services researchers around the learning health system and about how they can be embedded within delivery systems. And as Sharon alluded to, our goal with these competencies was not to leave them on the shelf, but to actually get these used by creating funding opportunities for training to develop centers of excellence and a new cadre of these kind of 21st century health system researchers embedded in systems. So stay tuned for that. We're very excited, and that's moving quickly. A second area, if you're on the workforce is one part of that, and there'll be other workforce ideas, but that was the researcher part of the team. Another area was the embedded technology that the learning health system has to have to be able to move forward. And this afternoon, you're going to go way further into what this could be. But right now, we're starting with the clinical decision support is not universally used. It is not universally accessible to clinicians at the point of care to drive evidence into practice. So led by our health IT team, and you'll hear from them later, two major initiatives. One is convening a national learning network of systems who are struggling to put clinical decision support systematically into their systems. And two, a targeted effort to create the really not sexy backbones and standards and tools that are necessary to make moving evidence into clinical decision support easy for everyone to do. And that's called CDS Connect. For the people who are doing it, it actually is quite sexy and the questions are fascinating. But it's very much a behind-the-scenes program, and that we are testing that, starting with cholesterol guidelines, the new national cholesterol guidelines, to make those universally translatable. This isn't driving that last mile and connecting it into individual health systems. It's creating what are called artifacts that allow any health system to customize and plug in and not start at the beginning of translating guidelines into clinical decisions. So we've developed the infrastructure. We're now testing it, and I'm excited that some of the important first testing work is actually helping in community health centers, aligned with AHRQ's mission of helping those most in need. A third area that's very important for us to point out is that when we talk about learning health systems, people often right away say Intermountain Healthcare. So thank you, Lucy, but we need it for more than just Intermountain Healthcare. And one of that is to understand a health system can be a single primary care office. It's at all levels of systemness, and Evidence Now, which you're going to hear about next in our presentation on primary care, is a large effort to work with over 1,500 primary care practices across the country and build their internal capacity to understand and apply evidence. That's looking at their use of data, their information systems, their workforce, their skills development, and actually getting them excited about putting control back in them to decide what's most important and helping them change it. And we're studying how that's working as well, but we are not thinking this is only for huge systems. The learning health system concept works across the healthcare delivery system. As hands-on and direct at the grassroots that our work in Evidence Now is, we're also taking a systematic look nationally, looking at larger data, and we've invested in what we're calling Comparative Health Systems Performance Initiative. It's actually a multifaceted initiative, but with three large grantees who are trying to understand what do health systems in America look like, how do we characterize them, and specifically, how are they using evidence? What are their systems? What are their measures? And then the goal is to be able to say, and who's doing it well? And to answer the question, what characteristics of healthcare systems are really empowering them to deliver evidence into practice and become learning health systems? So this initiative is a more system level for the whole nation, where Evidence Now is actually on the ground with primary care practices. So 4 examples of the different ways AHRQ could approach this. Jamie, you ready? I'll turn it over to you to say, now, okay, so we're starting it, but we really want to know where in the future our initiatives can be targeted.
So as David mentioned, we've obviously been thinking about this and doing a lot of work here. And so AHRQ commissioned a NAM meeting on June 29th to help advance the vision of the continuous learning health system. This builds on the report that NAM had published in 2012 called Best Care at Lower Cost, The Path to Continuously Learning Healthcare in America, as well as ongoing discussions that NAM is leading through their leadership consortium for a value and science-driven healthcare system. This particular meeting had a focus on the potential for AHRQ contributions. And I think the big takeaway is that there was a lot of impressive health leaders who are in healthcare, including Atul Gawande, Peter Pronovost, Reed Tuckson, and our own Mary Naylor, who also served on the committee who wrote the report on learning healthcare systems. And there was incredible excitement about thinking about this in respect to AHRQ. And the outcome of this will be a prospectus paper that'll be available in late August, and we'll be happy to share it with you when we get it. The meeting was structured with panels addressing these core questions. You know, what constitutes a learning healthcare system? How might learning healthcare systems be implemented? And what strategies exist for spreading the vision of continuous learning? You know, we're looking forward to reading the perspectives document produced by NAM, and the results of the meeting will actually serve as, we'll hope to influence our own AHRQ Research Summit that's scheduled for September 15th, 2017. And this year's summit, we're focusing on learning healthcare organizations. The goal of our summit is to explore how AHRQ can act as a catalyst for the advancement of learning healthcare organizations and practices. And this is a really exciting meeting for us, and it will be particularly interactive, where we at AHRQ and the participants in the meeting are going to actually create the content together. It will be a one-day invitation-only meeting, and it'll bring together about 80 different thought leaders on learning healthcare systems, including researchers, representatives from delivery organizations, both integrated, like Intermountain and Kaiser, but also smaller practices as well. And we're really looking forward to getting a good roadmap for us to move forward from that.
So it's been about 8 months. It's been about 8 months since you gave us the green light. That's where we've been. That's where we're going. This session was actually not designed to re-engage you in telling us what to do, though we are always open for that. So as much time as you want. This was really just to let you know what we've been doing. We're always interested in hearing your thoughts.
Kevin?
Great. It's great to hear the progress that's been made, and I think it's wonderful progress. I think it's a great area. I think it's a really important role for AHRQ, and I think you're very much on the right track. Couple of thoughts. One, I mean, Bridget, one of the slides you showed, you mentioned case studies, and where I'm sitting in my health systems and also dealing both in academics but in the nonprofit sector, more integrated systems, and then thinking about more in primary care clinics, particularly in safety net, there's a real need to have some examples of how health systems organize this. Particularly the investment that, like, are there some best practice, bright spots where, the big pushes are organizations willing to invest in the capacity to really do this, the analytics, some of the leadership from clinician and organizational leaders. So I think it'd be really helpful to say, yeah, here's some organizations that have created their offices of learning health system. This is what it took. This is what they're investing. This is where they've been able then to pull in some extramural grants or something. But because I think that's the big action potential threshold I'm seeing is, are you willing to actually put in this much FTE of analyst time to be able to mine your EHR data, related data? Are you able to have some leadership that identifies here are the priority issues that we really need some better information on in the application? And I've seen some organizations that I'm impressed at what they're doing, and I think it'd be really, I'd love to go back to my organization and say, see, here's what other people are doing, and this is why they thought it was worth doing. So that's one thing that I think would be helpful in the short term, to get some examples of the best practices here, particularly those organizations that invested some of their own resources to get this done. Second is, and I'm really glad you mentioned the Evidence Now in primary care, David. I think we can't lose sight of primary care as their own learning health systems. It's not just big hospital-based or integrated systems. And I think I'd be interested in your thoughts. So this one is a question. The first one was more a suggestion. Is how do you see this connecting with the whole practice-based research network arm of AHRQ? Or the body language is saying something. So not just the Evidence Now, but I mean, there, you know, AHRQ has played such a key role in the PBRN stuff, and I would be thinking, how do you help PBRNs think of themselves as learning health systems and advance their sense of research kind of methods? Like, sounds like.
Yeah, Kevin, I don't think I have to add anything to that. That's a great suggestion. We are thinking about it, and we both want to see small, and not just primary care, but small offices, even specialty offices, adopting these principles. We think their quality will improve when they, as a microsystem, do this. But the real power in data will come when we can connect those small independent practices so they have a larger set of data to look and learn from. And that's the regional extension idea can do that. PBRNs can do that. ACOs can do that. AHRQ we see as a catalyst for creating these systems where data flows not just internal, that it does flow internally, but that it's shared in larger ways. And so that's an interesting set of questions which we hope at the summit to address.
Yeah, and if I can just follow quickly, not to belabor, but yeah, I mean, with the PBRNs, because I mean, AHRQ has had, I mean, you have the PBRN conference still, right? And I mean, have you put this to PBRNs to say, what's the model of research that's beyond a little bit, what's the natural history of headaches? And I mean, there is, but how would we, what would it look like to really start thinking of PBRNs as learning health systems, not in the tradition, I think a little bit old school primary care research. So I wonder if you could challenge them a bit in this area.
For many years I've tried. I will continue.
Keep at it. Keep at it. All right.
Monica.
That was actually my question. But I also did just want to commend you. This is a lot of work in a short period of time. I really can see and appreciate the enthusiasm and the innovation and just all of the hard work that's being put into this. And so just wanted to thank you guys for doing that. But my question was sort of how this would be integrated into the existing infrastructure with the practice-based research networks and how that's been thought out.
You come up with a, even a better answer from Monica.
I'd love to listen more and hear what you're telling us to do, then tell you, okay, because we will. We'll take that back to our teams.
Sandy.
David, I think it's great what you guys have done and are doing, and just want to encourage you. Just two thoughts. When I was taking care of patients, I learned pretty early on that it's a lot easier when you look at a chest X-ray to identify a broken rib than the missing rib. The problem that's in front of you, and I think as AHRQ, we have to think. The people who are delivering care, whether we're physicians or nurses or organizations, are so focused on our challenges today that we sometimes don't think about what's going to occur 5 or 10 years down the line. But both the time frame and the mission of a group like AHRQ is to anticipate that, so the information and some of the problems have been anticipated and even informed by the time they arise. And that leads to two thoughts. One is I really want to emphasize that we always talk about, and 90% I'm sure what you heard was about evidence-informed practice, but the practice-informed evidence that you mentioned. And with that, something I didn't hear and I'd encourage you to think about adding to your 4 basic things is what I think is the critical fundamental role of AHRQ in assuring that the data we have on which we're going to develop this evidence is valid, that it's technical validity, that it has analytical validity, and that it has clinical validity. Because I'm very concerned as a researcher and as a physician, involved in my healthcare system, and ultimately, I guess, as a patient, that we take data that we know is not right. Sometimes it's not even wrong. It's so bad. But we use it because it's what we have. And I think an important opportunity and need and role for AHRQ is to focus on and take the lead in assuring that the evidence that we're developing, no matter where it is across the various databases or whatever, one thing with the budget, again, the quality measures is proposed to be dropped, but I think there are important elements. And I can see why Congress might think that way. They may think NQF is going to do it all or somebody else is going to do it all. But AHRQ has a unique perspective of what is important to make a quality measure valid and reliable. And I just want to encourage you guys to do that. The other thing that when I look back at some of the compendium of mistakes that I have and continue to make, I think one that I sometimes have not anticipated fully is you had a great conference in June of about 50 thought leaders. You're going to have about 80 in the fall. You've talked to a couple dozen people in between. But when you publish those reports, you always get back really good thoughts from people who weren't involved. They can be grassroots peoples. They can be systems leaders you just didn't talk to because you have limited resource and time. You might think about now a strategy to handle those comments as they come in and screen them and figure out which ones look like they may warrant further thought and merit, but sort of anticipate that in advance. And I just say that because you always do that, but you're on such a rapid time frame here that to anticipate that I think would be helpful to you guys to make sure that, because sometimes the best ideas come from the most unlikely sources, not from the so-called leaders.
Lucy.
So I'd like to echo the comments. Thank you very much. This is incredible progress, and it means a lot to the field. 3 points I'd like to make.
I wish I acted that quickly on my own suggestions.
Me too. 3 things. I think the point that Don was making about how do you differentiate AHRQ from other agencies, I think this is a direction that will be really important for doing that and make that case easier. And then the point that Kevin was making in terms of how do you leverage existing AHRQ resources and capacities. And the one I haven't heard people talk about is the action networks, where you already have partnerships with learning healthcare systems of various degrees of sophistication and size. And so it's another opportunity that you have. And having been a director of a program director for an IDSRN and then Action 1, Action 2, and Action 3, I can tell you that in the trajectory of that, we've gotten away from the learning healthcare system. And if we could go back to the roots of the IDSRNs, because one of the big challenges that we have in the field, and this was acknowledged in the slides, we have this rich resource of practice-based knowledge. And the learning healthcare system, in large part, does not have the incentive to publish in the peer-reviewed literature, even though they're sort of holding on to this knowledge, and there's not really a mechanism to share that. And a lot of the more recent action task orders that have come out have been, they're behind where the field is. We would have had to go back in time to sort of implement and test a lot of those things. So if there's a way to get back to that and to think about not just funding these things through grants, because I can tell you, by the time a grant gets funded, the question's gone. And so using those contractual mechanisms, I remember under IDSRN, there were a couple things, we wrote the proposal and were funded within 2 weeks, and we were in the field doing the work. That was pretty amazing. And so I think if you're going to build this real partnership with delivery systems and, generate evidence, and I would say, Brent James was just at a meeting I hosted at Kaiser Northwest, and, one of the cases that a lot of us have struggled with is we get these evidence-based guidelines that get produced and promulgated, but they're not validated in learning healthcare systems. And so you have this natural partnership ability, and I'd really recommend that you sort of think through how do you engage them, how do you meet the timeline demands, and how do you sort of harvest that practice-based knowledge and take it to a higher level.
So Christine, you took your card.
I'll turn my mic on, just some basic questions. On one of the slides, you talked about developing and maintaining large comparator data sets. How will you do that when we still can't seem to find variables that match within one system? I mean, I'll give you an example. I went from Penn during my fellowship at CHOP to my prior institution to where I'm at now, which is a very large 3-hospital system they all use Epic. I could tell you, I could look at Epic at when I was just trained. It looks nothing like the prior 2 hospitals. So, and then I think as a primary care provider, I practice still. My system looks nothing like Epic. In fact, I know most even health systems don't connect their primary care practices. There's nothing continuous from primary to acute care. Sometimes you have to dig through data to find out why the patient was even admitted or referred from the primary care institution. And what we get back from institutions is very difficult to even find within the system. So I'm just really curious, and it goes back to our need for a standardized system somehow. Like I'm always surprised we never have the major EMR organizations at the table explaining that.
We don't even have a typology that the terms are used the
Right.
same by different providers. When you say heart failure, you mean what Lucy means when she says heart failure. That means what I
That's
mean
right.
too.
And even, I think, I'm working with some folks. We were at Children's Hospital Association at a recent quality safety meeting, and we talked about looking at nurse practitioner metrics. There's not a lot with pediatric nurse practitioners. We're in the midst of, there's 5 of us, 5 different major children's hospital systems. None of the language matches. So how do you look at outcomes even in primary care when you can't even look at the same variable and say, that's what I think they meant when they put that in. So I still, I look at it again. I was still floored again as I sat and had to do EPIC training again. It just kills me. But anyway, you look at it and you say, why are we doing it this way? No wonder we have these huge data sets that take forever, but we need the resources to connect the institutions. And you win a Nobel Prize in my book if you can figure that out. But I don't. How are you doing? So how are you going to do that? Is, I guess.
So
back to my.
The most important thing I should say that Bridget gave you is what we heard from the field. I promise you, we're not able to do all of these this year. But yeah, well, let's go for the Nobel Prize. Let's change the world by shooting for
Sure,
these kind
if we
of
could
things.
standardize
And
it, great.
It's about that data stuff. So this afternoon, we're going to be listening with our learning health system part as you work with Gopal and the team to talk about data analytics. These aren't separate. These all have to come together if we're going to make this work.
Even I guess my whole thing too now is just having recently found out I did not, and I didn't share this, have mumps immunity, was exposed to one of those Penn State students who had mumps. So I happen to, look back and go, that's great, but we don't even have vaccine surveillance down to a science yet after all these years. Like there's no database in the state I was in Pennsylvania where I could immediately access and know who has their vaccines up to date, something that simple. And I just, as a primary care provider, I think that's it, that's critical, where we are seeing so many non-compliant vaccine folks out there that that's another example within the primary care setting. I'm sure that'll come up in your discussions with family practice and with primary care. So just connecting that dot too would be great.
Don?
So 2 separate comments. Going back to one of the slides you showed, it was about healthy hearts in rural primary care practices, something like that. And I was just trying to remember the acronyms and searching for it, and I can't find exactly what it was. But as you probably know, Robert Wood Johnson and others funded a major, I think it was 7 states ultimately participated in how to get evidence to base practice in rural health. And some of those states did very well. I think North Carolina was one of them. Arkansas arguably has a premier program in reaching rural primary care practice using agriculture extension service models, been very successful. So I hope that, I trust that you'll be going back and studying those exemplars rather than saying we got a heart problem we got to solve. Getting back to my comment about opioids, I guess.
Well, so it's a great question. You're going to learn a lot more about Evidence Now. Evidence Now, actually, though, is not rural. So we're conflating. We did do a opioids, medication-assisted therapy, because the country said the place where we need evidence is how to get those communities engaged. So we have a very targeted, small program on improving medication-assisted therapy in delivery through primary care, though interestingly, it's not about just the practices, it's about community and statewide resources to empower those practices as well. Yeah. IPIP, the RWJ, was absolutely, we were part of and built on. Some of their leaders are here today, and continuing North Carolina is one of our models. So we are committed to learning and building, but these kind of things, like I didn't know Arkansas. So share with us. We're always interested in learning more. But primary care is coming up. You're going to get more on this.
And the other comment has to do with learning. learning healthcare systems, and this is familiar. Lucy and I have talked about this a lot. Sometimes I feel like I either have two heads or I'm in two different worlds when people talk about learning healthcare systems. So I'm really looking forward to this product of the NAM meeting. That said, right away I'm feeling dichotomized because most people, when they talk about learning health care systems, which you will be doing, I think, this afternoon around data, are talking about the rapid use of data to understand and improve healthcare delivery. The sentence that you have on your slide was under wider use of evidence after early successes within a limited clinical area. That has nothing to do with data. That has to do with implementation science and how you move from innovation to scale up and spread. And there's a whole scientific basis for that. The data you need for that is improvement data, not data in databases. You need some databases to monitor whether you're successful. So the epistemology of learning, if I can use that term that I learned just 3 years ago at a fancy meeting, is very different whether you're moving from innovation to local implementation to scale up and spread than it is from how do you use data to drive improvement.
We're fully with you, and this is our model, but you can see we have the two goals. It's both, the first one has two parts, that it says it's about learning data evidence that's not your own. How do we move evidence into practice, the 17-year problem, but it also is about your own data, and those take different things. And then, for us, the combination of what makes a learning health system is that and the ability to move into practice, which is implementation. And you're right, requires other skills and sets. And people will often get stuck on only one arm. And it's helping everyone understand that implementation is not the same as research, that there are different data sources that clinical care provides, but it's a higher order we're trying to move towards. So hopefully we'll be able to show you stuff that you'll respond to and say, yeah, you're getting it, but change this or add this, because we're not there yet.
Recreate me into a whole human being. That would be great. Just one thing to note, actually once wrote about this on what a ready-to-roll comparative effectiveness research setting would look like. And there actually it's remarkably difficult to find them. I mean, when you talk about grants being given to organizations, they're very happy to go test something in general if they are qualified. If you're talking about asking them as part of routine work to begin implementing testing, spreading, real in their own benefit, volunteers are scarce and successes are few. And where you do have these settings, they may not be fully interprofessional, interdisciplinary, using all the resources they have at their disposal. I remember being in Providence system in British Columbia, and the people at the front line who were trying to do all this work had no idea they had a whole health services research program in a different building with behavioral scientists and human factors and user-centered design. Never, ever had the twain, whatever that expression is. So that remains a challenge. As long as you provide funding to organizations, they will do stuff. Then will they develop the kind of interprofessional, interdisciplinary network in their own system that can actually test on their own accord, on their own dime, what they need to do to improve?
So you, I think, can hear a lot of enthusiasm and support for the work and lots of additional ideas. I'll just add one before I tell you how we're going to deal with the timeframes going forward. And that is, I wouldn't underestimate the importance of culture and the need to actually help people become open to learning. And we see this a lot, I think, in healthcare delivery, where people on the front lines, and this is a part of another initiative you're talking about, feel completely overwhelmed. And the idea that they're supposed to change how they're doing something that they believe is right today and they think they know how to do really requires, I think, both a culture shift and capacity building. And so I just wouldn't want to leave out that piece of it as you think. And in fact, I would, in some ways, I think that the culture piece becomes important, and we, this is something that we learned some at Kaiser Permanente just in the quality improvement space, that you needed to not just have leadership engaged, you need the front lines to have the capacity to be a part of that process. And I think that's likely to be equally true here, along with the tools and everything. But having seen some things that didn't get put into practice where it seemed like all the right things were there, there were huge cultural barriers and fears and concerns. Will I lose my job if we put this new thing into, things that people didn't really completely understand were getting in the way of adoption and implementation. So anyway, just because you needed more to put on your plate, I thought
we are completely aligned with you on that. We actually talk about leadership, governance, and culture as part of this, equally as important with the technology and the analytics part. And what we're finding is some people want to go to the analytics and some people want to go to the cultural, and we don't know, do you need one before the other? And that would probably be the leadership and culture. And most likely we're going to have something that allows wherever you are, whatever you've got, how do you spiral to the next step and then take to the next step, and helping the data people get the culture and the culture people get the data, because without both, we don't think this works. So we will continue that focus on leadership, culture at the front lines, and this actually works against some of our other work, reducing burden, actually getting to the place to understand, getting into that mindset that change is coming and that's a good thing, actually often causes a decrease in morale.
Right.
It burns people out, and we don't have much room for burnout anymore. These folks are struggling, and so how do we make this empowering without burning them out is another Nobel Prize, I think.
We look forward to those Nobel Prizes. So here's what we're going to do. We're going to take a really brief bio break and then come back and get the update on Evidence Now. We anticipate that may cause us to need to do a working lunch while we talk about the data and analytics issues. But if you weren't so darn engaged and so determined to provide our helpful guidance, we wouldn't be in this problem. So let's just take a brief bio break, try to come back in 5 minutes, and we'll move to the update on Evidence Now. Thanks.